Respected Chairman Dr. P.S. Taha in his absence, teaching faculty, and my dear students. Today, we have organized a talk as part of awareness of World Cancer Day, that is the February 4th. And the resource person for today is Dr. Vivek V. He is the professor and head of Department of Oral Medicine, PMS College of Dental Science and Research. The primary goal of World Cancer Day is to significantly reduce illness and death caused by cancer. And it's an opportunity to rally the international community to end the injustice of preventable suffering from cancer. The theme of this year's observance is Close the Care Gap, which is primarily intended to increase the awareness about inequities in cancer care. Sir, I request you to commence your lecture.
Thank you, Dr. Rajesh, for the introduction. Respected Chairman Dr. P.S. Taha, Principal Dr. Rajesh Pillai, Dean Faculty Dr. Sudhir, colleagues and friends. At the onset, let me offer my prayers to God Almighty for all His blessings. I place on record my gratitude to our Chairman Dr. P.S. Taha for immense support and guidance, and it is because of his support and guidance that this program is also possible. Today is World Cancer Day, that is 4th of February, and it's actually an initiative of the Union of International Cancer Control, UICC as it is called as. So we observe World Cancer Day on the 4th of February every year. Oral cancer, today's theme of the presentation is Close the Care Gap. So that is exactly what the World Cancer Day means. And it is not a single program that they have envisioned or just close it down after this particular day. It is not like that. So it involves recognizing the power of knowledge that each and every person, each and every single person can make a difference in cancer care. And then also, if you work together, we can reduce the global impact of cancer. So this recognition is what is expected when you speak on the or when you perpetuate the idea of close the care gap. So on this 4th of February, actually the organization or actually the people who are involved in cancer care call upon you. It is that you that is very important as far as cancer care is concerned. Whoever and wherever you are, to play your part in creating a cancer-free world. So that this World Cancer Day, what will you learn about the gaps in cancer care? So that is the most important aspect that we have to look into today during this World Cancer Day. And World Cancer Day is more than a single day. It is considered, or it is envisioned to be a 3-year campaign, and especially starting from this year, they have envisioned it to be a 3-year campaign, basically to inspire, challenge, and mobilize action against cancer, or to help cancer patients and to help live through the days of cancer. And it is actually a multi-year campaign, which is designed for creating more exposure and engagement in cancer care, and also for creating more opportunities for global awareness and also for impact. So this 2022, the first step in this 3-year program is realizing the problem. So what is the problem? The problem is that we have to recognize the inequities which is existing in cancer care. Inequities in cancer care essentially means that there are a lot of challenging factors. There are a lot of confounding factors. And some of them are very hard and undigestible facts, which you have to look into these facts with an open mind. So that is the first step towards cancer care. Rather, these steps have been taken even before, but this is something which we have to pledge and go forward again right from today onwards. And the hard facts that we are looking into is that there is inequity existing regarding cancer care in cancer care. And these inequities can cost lives. And another hard fact is that a cancer patient hits a barrier at every turn in their life, or at every turn they are living with the disease. And even during cancer care or during treatment and after treatment. And these barriers range from a simple physical discomfort, or rather it is not a simple discomfort, it's physical discomfort, to financial burden on the family. So the factors affecting care again range from income, education, then location, discrimination of all kinds. All these factors come one after the other, and they stare at the cancer patient. So we are looking at these gaps, and these gaps affect each and every one, which include you as well as your loved ones. And the barriers which I have been talking about is not set in stone. It is not very hard. Even though it seems very hard, they can be changed. And the main reason they can be changed is that we have to reduce the inequalities which are existing as far as cancer care is concerned. Then the action required. So what do we do towards this particular removal of these barriers? The first is you have to start questioning the status quo and help reducing the stigma associated with the disease. Then we have to listen to the perspectives of people living with cancer. For example, like when we were actively involved in cancer screening and cancer detection, we had gone to the fishermen community who has a little bit of higher incidence of oral cancer, especially in the coastal areas. The main problem was that you tell them that this is a problem that you are having, and you probably might be having or might be developing. You are indulging in habits that can perpetuate or can give rise to oral cancer. But what they say is, see, if I get oral cancer, there is a probability of getting oral cancer. And if I get oral cancer, what is the main problem? I may probably die in another 10 or 15 years or 5 years from now. But what the habit that I'm indulging in is to keep me awake in the sea, in the middle of the sea, where there is nothing. I am myself and only my boat or the catamaran, whatever they are sitting on. If I do not keep my lamp burning, some other boat is going to hit me and I am going to die today. So to keep me awake, I am indulging in this habit. I am not bothered about what that oral cancer is going to bring me in another 5 or 10 years. So that is the perspective in which these people are living in, and they are also perfectly justified in making that particular statement. So we have to listen to people, and mind you, these people, most of these people know that some of their friends as well as their relatives had oral cancer before. They had treatment for oral cancer, and they know the reasons for oral cancer also. But still, they are indulging in the habit because it is addictive, and secondly, they have a justification of keeping them alive, keeping them awake, which may probably keep them alive at night. It is like that. So we have to experience what exactly is the problem facing the people living with cancer, and then find out working solutions for them, and let lived experiences guide our thoughts and actions. And we have to mold ourselves to do like to think in terms of having a better way of doing things, so that we can build a fairer vision of the future. Future means we have to have healthy lives, better access to health and cancer services. So again, I remind you that this World Cancer Day, you have to think of what you will learn about the gaps in cancer care. The next year, that is 2023, the action that is required is to build momentum to fuel the fight for fairness. That is, we have already identified, we are expected to identify the inequalities existing in cancer care during this year. The next year, we have to fight for this fairness. And that is reducing or eliminating the inequalities. And we have to build strong alliances and innovative collaborations so that so as to motivate people, so as to motivate the masses. And see, each, like I said before, each and every one of you can contribute. You might have listened to a lot of people who provide transport, free transport to people with cancer. So even you might have listened to a lot of news regarding auto rickshaw drivers or even taxi drivers who provide free transport to cancer patients to RCC. So such initiatives, whichever is possible by each and every individual, is what is to be identified, and they have to be built up into very strong alliances and with innovative collaborations for providing healthy and affordable transport, as well as nutritional options for the cancer patients. Not only that, there are so many other things that are required for a cancer patient. Lot of hurdles they will have to face. So each and every hurdle has to be identified, and each and every person who is working in their own field can of course contribute to cancer care of cancer patients. So essentially, in 2023, we plan to mobilize and mobilize resources, not only resources, mobilize manpower also, with the intention of having a very strong and a united network which will contribute to cancer care. In 2024, the attention is to engage our leaders, to raise the level of the cancer care, to involve leadership into this particular program. Leadership, of course, it's already involved, but still we want to put them in a different perspective and contribute to cancer care. And here we are expected to shake the very foundations of injustice and become lifelong advocates, fully equipped to push for a lasting change. We have to demand and confront and eliminate health inequalities. And we have to prioritize cancer treatment, cancer care, rather. I would like to call it as cancer care, because cancer treatment forms only a small part of cancer care. And we have to look into creating innovative strategies for a just and cancer-free world. And we have to invest our resources also. So this is the theme of Oral Cancer Day, and this is the this is what is envisioned in saying that this is Oral Cancer Day. And as I said before, it does not stop with a single day. It is a continuous process. So now like as a first step, we being dental surgeons, let us have a look. Our primary concern is oral cancer. So now let us have a look at the world statistics. World statistics says that it is the sixth most common malignancy with an annual incidence of more than 400,000. And WHO considers it as a public health issue also. What is the Indian statistics? The Indian statistics, this is a screen print of the cancercareindia.org or cancer statistics, the latest cancer statistics. Our total death due to cancer in 2018 is 7,84,821. So that is the total cancer death in our country. And cancers of the oral cavity and lungs account for 25% of the cancer death in males, and cancer of breast and oral cavity accounts for 25% of cancers in females. So if you see the table which is given below, you can see that oral cavity cancers rank the first among men, and among women it ranks second. So this is the Indian statistics. So keeping these statistics in view, you have to have an idea, a few things to note regarding oral cancer. Regarding oral cancer, it is very highly unlikely that oral cancer will appear in somebody's mouth one fine morning. Most of the time, it is associated with the habits. Most of the time, the habits slowly proceed to precancerous lesions or conditions, and after that, appearance of precancerous lesions and conditions, now it is called as oral potentially malignant diseases, OPMD. These lesions and conditions, it's already gone, but the terminology now is oral potentially malignant diseases, OPMDs as it is called as. So these OPMDs, after its appearance in the oral cavity, if you see, if you still continue the habit, there is always a chance of a person developing oral cancer. And identification and elimination of these etiological factors can mostly prevent cancerous changes. So essentially, oral cancer is mostly preventable. Early detection can reduce morbidity and mortality associated with oral cancer. It's another important thing to note regarding oral cancer. And since these habits, especially pan chewing and the other like pan chewing and tobacco use, except for smoking, it's very common among the lower income group. And as our Bhavnathas always says that oral cancer is a poor man's disease. So definitely it boils down to the fact that it can be, or it is, a public health issue also. So now I have just put a lot of pictures in this slide, which can which is the etiology of oral cancer. We have both smoking and smokeless tobacco as the major cause of oral cancer in our country. And along with this, there are so many other confounding factors like genetic predisposition, HPV, human papillomavirus infections. So a lot of other factors also come in. But primarily in our country, it is the tobacco use and the tobacco and arecanut use that can probably contribute to oral cancer, or this big burden of oral cancer. And here again, due to lack of time, I have just made a collage of the different OPMDs, and which will contribute to oral cancer, which is kept at the center. So these are some pictures of leukoplakia, erythroplakia, then lesions associated with reverse smoking, then stomatitis nicotina palati, and sometimes these lesions can start bleeding also. So and on the other side, you can have a look at the different presentations of submucous fibrosis. So submucous fibrosis is also another disease or OPMD that can probably develop into oral cancer, and it is a typical example of a disease which can contribute to feet cancerization. That is, multiple primary appearing out of multiple primaries appearing out of a single lesion or a single condition, and also like which doesn't have any connection with each other. So field cancerization is very common with submucous fibrosis conditions. So essentially, oral cancer, another thing to note regarding oral cancer is that it's the most curable cancer as far as human beings are concerned. And the survival rate is expected to be more than 80%. Early detection reduces mortality and morbidity. But still, I have put a round around this. Our last 5-year survival, 5-year survival rate in the last 5 decades is still 50% or even less. What is the reason for this low survival rate in spite of oral cancer being the most curable disease? The main challenge is that there is lack of awareness, even with the even in the presence of multimedia, social media, and also different inputs regarding oral cancer. Awareness is still lacking. Awareness is still lacking. There is a lot of work to do regarding creating awareness regarding oral cancer. And most of the time, what happens is that oral potentially malignant diseases rarely show typical clinical features, and it is easily missed. Another problem with oral cancer is field cancerization. Field cancerization that can occur, and the incidence of secondary primary tumors, which is more than 3 to 7% per annum. And this is it's a figure which is higher than that for any malignancy. And secondary primary tumors or field cancerization is again a common cause of treatment failure and death. And this very specifically occurs associated with submucous fibrosis. So what do you do for this? So the first step is early detection of oral cancer by professionals. But the main problem is that dental surgeons, the person who is having a potentially malignant lesion or a potentially malignant lesion should go to a professional like a dental surgeon or an oral medicine specialist or a practicing dental surgeon for that matter. Instead of that, secondary prevention, which is done by our Department of Public Health Dentistry, so like increasing public awareness, conducting oral cancer screening programs, and regular oral cancer screening programs, especially in societies or in population where use of use of tobacco and tobacco related products is very common. So in such areas, if you keep on conducting oral screening, oral cancer screening, and screening for oral cancers as well as OPMDs, that is potentially malignant diseases, we can detect asymptomatic cancers as well as oral pre-cancers and give them proper advice and motivation for leaving these habits. So this is a very important step in early detection and treatment of oral cancer. So how do you identify oral cancer? I'm not talking about the clinical guidelines which is used for identifying oral cancer. The venues where you can identify oral cancer. That's what I intend to speak. The first step is oral cancer screening, either self-screening or a professional screening. You have to encourage each and every person to look into their own mouths properly, look at all areas and see whether there are any white patches or red patches or speckled areas like that. So, of course, to identify these lesions, you require special training and special uh, uh, orientation. And that can be provided even for a normal person who is not at all connected with dentistry or medicine also. Volunteers, NSS volunteers, then volunteers of NGOs. So all these people can also be trained for um, screening or as part of self-screening. Then professional screening definitely has to be done by dental surgeons as well as oral medicine people. And once we notice the early changes in the mouth or the throat, we have to go in for a diagnosis, and then after that, the management strategy comes into play. So here again, I come back to the first statement, that is the most important person in identifying oral cancer. It is you, and it is you who is very, very important, and it is your alertness, and it is your identification skills and management strategy that is going to be very important. So now what do you look for? A lay person or a volunteer, or for that matter, a general practicing dentist. What do you look for? The first thing is like you look for sores or lesions in the mouth which is not healing in 2 weeks. A lump or a thickening on the cheek which is existing there for a long time. A white or a red patch. A chronic sore throat. Then sudden difficulty in chewing or swallowing. Difficulty in opening the mouth. Difficulty in moving the jaw or the tongue. Then numbness of the tongue or other areas of the mouth. Swellings of the jaw, which can contribute to ill-fitting or uncomfortable dentures. That is very recent. The person has been using dentures for a very long time, but very recently it has become ill-fitting, it has become painful, wearing of dentures have become painful. Then chronic hoarseness of voice. So all these are changes that can probably indicate the presence of oral cancer. I am not saying that it is indicative of oral cancer, but most of the time it is some other less serious problem that is the reason for whatever I have described in this particular slide. But there is a small chance that it can be because of oral cancer also. So who will make this identification? Once you identify any of these problems, it has to be professionally identified and it has to be investigated. So you have to consult an oral medicine specialist so that the identification of the lesion becomes early and it becomes easy. And it's not only identification, probably you may not be able to come to a conclusion come to a single conclusion or a single diagnosis. We may have a differential diagnosis, and we have to correlate this information with tobacco habits and pan masala habits, which has been implicated in development of oral cancer. And for suspicious lesions, we have to go in for a biopsy. Biopsy is still the gold standard for confirming oral cancer. So once oral cancer is detected, what do? There is always a tendency for the people to try to manage oral cancer themselves. I personally consider that it is one of the most dangerous attitudes that you can ever have. Why? Because cancer treatment, cancer management involves an interdisciplinary approach. It is not a single man's prerogative. It is not a single man's diagnosis. It is not a single man's contribution in treatment. Whatever you are treating the oral cancer patients. It has to be a collective approach. So definitely, it is always recommended that once you have identified oral cancer, you have to send the patient to a cancer treatment facility. In our place, it is the RCC, or there are hospitals or institutions with cancer treatment facility. So what happens there? What happens there is that the cancer patients are examined properly. Investigations like and even advanced investigations are done, and the clinical features and the investigation findings are looked into by a tumor board. Tumor board is not a single person. It consists of a collective, collection of people who are experts in their field. And they sit together, analyze each and every problem, and they come up with, or they discuss and come up with the best treatment option, which option for that particular patient. So tumor board and tumor board programs are very, very important, and a treatment will come out of that particular discussion. And in most of the well-run institutions, it is the tumor board treatment that is in a practice on the patient, or that is instituted to the patient. So that is very, very important in cancer care. So to summarize, oral cancer is a preventable disease, and habits can lead to oral cancer, or habits like especially tobacco chewing and pan masala chewing. And of course, our state has by legislation banned pan masala in packets. So I would like to call them as oral cancer in packets, whatever it might be. So whatever it is, habits definitely contributes to oral cancer. Sudden development of oral cancer is very rare, and oral potentially malignant diseases often can lead to oral cancer. And oral cancer screening is essential for early detection of oral cancer, so that the mortality and morbidity can be reduced. And for suspicious lesions, always consult an oral medicine specialist, so that early identification is possible. After which biopsy and whatever is required can be done, and proper care can be instituted to the patient. So I would like to say by saying that you can help in cancer care, and this and the program, I think, should start from today, and it should continue in the next coming years also. Thank you. Let us work in unison to stop this menace of oral cancer and help in cancer management. Thank you. I take this opportunity to thank our chairman, Dr. P.S. Saha, for being the leading light of this institution. I also thank for being a proactive person and a positive person, and for giving me this opportunity to address this online program. I remember with gratitude the guidance provided to me by individuals whom I consider my mentors. My guide, Dr. Srilada, retired JDME, Dr. Anita Balan, and also Dr. Bob Matthew. I also thank my colleagues in oral medicine, Dr. Sunila, Dr. Jinsi, Dr. Devi, Dr. Ashwadi, Dr. Shiana, Dr. Benila, and also Dr. Shabna, for all their support in making this program possible. I also also express my gratitude to our computer specialist, Dr. Sujit, as well as Dr. Biju, for all the support they have given me in conducting this program. Thank you.
So thank you for a wonderful lecture. Even though you were informed at the last moment, you have gone through a lot of pain in preparing this precise PowerPoint slides, I think, where you address the matter and never ever deviated away from the topic. And where the oral medicine specialist really comes into the picture, even though I consider myself a private practitioner, many a times I think these precancerous lesions escape our notice. Don't you think so, sir? Like we always look at it from the restorative point of view or from an endodontic point of view. Many a times the oral lesions miss our notice.
This is Dr. Rajesh, thank you for bringing this particular topic into discussion. It is a fact that a lot of people are missing missing OPMDs, precancerous lesions. One thing which I forgot now, I am remembering, and at the same time, let me place it on record. That is, see, one thing which is very important: sharp teeth. Sharp teeth and chronic injuries due to sharp teeth can also contribute to oral cancer. This I have forgotten to introduce in these slides. So this is one very important thing which we have to look into. And traumatic keratosis or frictional keratosis, which is there for a very long time in the mouth, can probably develop into oral cancer also. So each and every general practitioner or any specialist who is practicing their branch of dentistry, please have a look into their mouth, into the patient's mouth, with the perspective of identifying mucosal lesions, especially white lesions and or speckled lesions. And if you can identify these lesions, it is better that you call us so that we can differentiate or make a diagnosis. You people are also qualified in making a diagnosis, but I personally feel that we are trained in this particular aspect a little better than the other specialities. So call us and we can make the identification. And once we do a biopsy, we can take the help of oral pathologists to make a confirmatory diagnosis. Even now, the oral cancer confirmatory diagnosis by looking into the microscope, biopsy is the gold standard. So we have to, so once the diagnosis and everything is done, all pathologists step in and they make a confirmatory diagnosis for the rest of the cancer care. And let me tell you my personal experience. I get references from some of the peripheral clinics very regularly, some certain areas very regularly regarding white lesions in the mouth. But I find very little references from some other areas. It is highly improbable that this disparity exists in certain areas and certain areas. In our, it's almost the same, white lesions and which may be normal frictional keratosis or some simple lesions which can be treated properly, but can probably progress into oral cancer later on. So this is very common, but the identification of these lesions, we have to put an effort. We have to identify that gap. That is one very important gap that we have to address during this particular World Cancer Day observance. Thank you, sir, for bringing this point into discussion.
Any questions from the audience? I request you to at least ask one or two questions to make the session more lively. So as there are no questions, I would like to conclude the lecture. So thank you for your wonderful lecture, where I would like to specifically mention, especially your acknowledgement for your teachers and your department colleagues, which is a rarity, I would say, in our present times. And Dr. Sunjit Sudhagar has asked one question. He has asked opinion on low-level laser therapy, sir, in OPMD.
Low-level laser therapy is it's very effective. Low-level laser therapy is very effective in management of OPMD, especially leukoplakia. Our Rajesh Prasad is doing it on a regular basis in our college. So it's very effective. My thesis was also on that, but it is not low-level laser therapy. It was proper NDIAG laser that was used for management of leukoplakia, and that has been published also before a long time back. So laser definitely is very, very important in management of diseases, diseases which are very confined, like leukoplakia, but it is not very effective in management of lichen planus. Probably it might contribute to a small extent. It might contribute to reduction in the painful situations of the pain or the pain generated from the erosive areas, but it is not very effective in lichen planus. The same signs and symptoms comes again. But with regard to very specific lesions like leukoplakia, erythroplakia, varicose leukoplakia, low-level laser therapy is very, very good. And even in fact, if you can excise it using laser and then do the ablation afterwards, very effective. Very effective.
Thank you, sir. Thank you for your wonderful lecture, sir. And we look forward to more of your pinpoint lectures in the future. Thank you very much.
Thank you, sir. Thank you.